I'll leave just a minute to Steven so that he can introduce himself, and I'll take the lead after that.
Well, thank you. Hello, everyone. My name is Stephen Ouellet. First, thank you for the opportunity to present our paper. This is very appreciated. I am 46 years old, and I was diagnosed with brain cancer in 2019. Uh, since then, I have wanted a patient portal to access my personal test results, for example, and to communicate more easily with my care teams. And this is why I submitted this topic to the AbSPORU Evidence Alliance. After that, this topic was selected and funded, and the results were published recently, as you said. I am also a research professional at the Université Laval at Quebec, as you said. But because, as you listen, my English is not very good, I will let Dr. Sasseville introduce himself and make the presentation.
I don't know what you're talking about. This is perfect English. Perfect.
Uh,
If you want to express yourself in French and let me translate, feel free as well.
Thank you.
So I'll take the lead. Moreover, Stephen is also a little sick today with a
Not because
virus.
my cancer, but I have the flu. It's
Yeah.
a couple of days.
So ridden with a virus.
Mm.
So I think I'll leave him. I'll let him get better. And if you have a specific question for him, I think you will, because I'm not interesting here. He is, and I'll give as much context as possible to how this happens and why it is shaped that way. I think the most impressive and interesting thing about this project is the patient-driven part, and it's probably what interests this group a little. So I'll try to give as much context as possible, or try to answer for Stephen or with Stephen by translating. So I am Professeur Maxime Sasseville. I'm an associate professor at Université Laval, and I work as a researcher at VITAM Research Center for Sustainable Health. Yeah, my research program is around technology implementation and with a specific lens on AI implementation. So I think I'll go forward and yeah, I'm sure you'll understand a little bit more where this project happened. So I am a member of the AbSPORU Evidence Alliance. Maybe because you're a AbSPORU subgroup, you probably know about this alliance. But I'm a regular researcher, but also a full member of this alliance. So how the alliance work is that we receive demand for knowledge synthesis from mostly decision makers, people from the industry, or people from healthcare contexts, things like that. And we offer methodological support to provide the knowledge synthesis. So we run the knowledge synthesis in partnership with patient, with knowledge user, with clinician. So we are used in experience with having just the methodological lens applied to us and having a content experience provided by our partnership with the decision maker, the patient. So how this project happened is that Stephen, there was a special funding call asking for patient partners around Canada to submit research question. Stephen has submitted one. We provided context. It was chosen for funding. It's a little bit under a third of the question that were selected, so it was a really good question and really well framed. And after that, they linked Stephen with us, with our team, to provide the methodological lens and expertise to drive this project. So it was a really good opportunity to do something that is really interesting, but I think for Stephen as well was he said he had a scientific background, but leading a project that is dear to him. I think he said it well, but the experience that he has, but also the need that he has, provided a really different lens than a scientific one for this project. So we had a lot of different discussion. So I'm giving you the context now, and I'm getting into the result of the paper after. But we had a lot of discussion, and right up front, we discussed about authorship, uh, and he asked about if he could lead the manuscript, and I was really delighted that he asked. So it was really led by him. It gave us a lot of barriers on the road by peer reviewers, for example, and by journal editors that were saying things that could be seen as inappropriate, but that the language was not good enough, or that he should have a scientific team looking at the manuscript. But our goal was to give him a lot of space so that the way he wanted to present things was still there, but with a methodological orientation from us. So that's why you see that Stephen is first and I am last. And you have Chloe as well, which was also a patient partner on the team that is in the author team as well. And after that, you have trainees, other researcher, but also a document specialist that provided the help for the structure of the search. So I'm advancing now. So the background for the project, other than the background, the context for it, for the funding and the matching between myself and Stephen. So that the patient portals, you probably think about portals in a way where you see any kind of interface where you can interface with your health data or the system where you get your care. This is probably the most the easiest way to think about it. In cancer, it was underexplored. We were not able to find any good knowledge synthesis that provided an understanding of what could happen if it was used in that context. So that was what fueled the first the starting of the project and also the research question. And we were thinking about anything that can be improved with engagement with health data and provider, but also some part of some patient portal provide also education. So you can think about self-management, self-efficacy, improve healthcare processes, but also improve health outcomes. We were hoping that maybe that could be the case. So that's where we started. The objective was firstly to identify this was a scoping review. So we wanted to understand the functionalities that are implemented. So in the context of cancer, what are used? What do people implement? What do scientists implement, or what do decision maker implement? And this was an addition from Stephen that was dear to his heart, but to understand the sub objective of using the Progress Plus, this was to understand the characteristic and equity consideration that are implemented or used or described. So we wanted to know if there's anything that is provided to give us that lens. Flash news, not enough, not enough, and not a lot of things. Super rapidly, but we use the GPI methodology with the Prisma extension for scoping reviews. This was four databases search. And we were interested in the concept of patient portals and in patient with cancer. We had a specific definition for portals. So what functionalities or what basic function do they need to have to be identified as a portal? You have that in the paper, and because you've read it, you probably remember well. But if you want to see the definitions there, and we add patient partners involved throughout the project. So from question elicitation, but all the discussion, because the first question was not exactly the synthesis question, as you can probably see or foresee. It was a restructured question to be aligned with what existed, but also what could be feasible with the amount of money and research that we had. So we had a lot of conversation and exchange about what could be cut or which orientation we could take so that it could be manageable for a synthesis. And I think we've talked about this before, Stephen and me, in other meetings about this work. But it was a lot more emotional than we anticipated when we had these conversation about cutting things that could be interesting for him. It was harder. It was a harder discussion that I ever had about methodological choices before. So it took a really good partnership between us and a respectful partnership, but also empathy-driven one. I think I was really I tried to put the lens of I tried to put myself in the shoes of Stephen while he was trying to do this work, but also on his side, he did the same. So what are the kind of things that I need to do as a researcher to be sure to not introduce bias or introduce problem? So it was quite great as a process, but it was a harder one than anticipated. Not in methodology, but in I think relationships. Here you have our Prisma flow diagram. There's a lot of studies included in this project. We didn't have a hand search arm. It was well defined enough so that it wasn't added, and this is a scoping review. So usually it's not really the orientation that you go in. For the included city, so these are mostly the description. You can see, so 44, I've said it, with a majority in US, quantitative design, but we kind of, so we were able to find a couple of mixed method and qualitative paper that were quite interesting into implementation processes. This was really, really great to see. The breast cancer was the most reported focused disease. Age was the most frequently progress plus factor that we found. After that, we found as well that they took into account socioeconomic status, race and ethnicity, and sex with a big asterisk, because sometimes they reported gender, but they reported gender as a binary outcome, which is sex. So it was kind of a misreported gender that is more sex than gender. And we didn't have intersex as well. We didn't find any intersex if I'm not mistaken, in the progress plus factors. It was always dichotomy.
You're right. We don't have any.
Thanks. He knows the paper better than me. I said it starting. So what do we found for function? Which is encouraging, most were focused on messaging. So having helpful structure around communication between a care team and the patient. Second was test result. So that was also quite encouraging. And Stephen said it best, that this was probably the thing that he wanted most, to be able to have access to his result and exam and appointments. So that's what we found first. But we also found interesting orientation around education and prescription, which was really, really interesting, because it provided a possibility for patient outcome improvement, but as well as interdisciplinary work that is a little bit more fluid. So patient portal that go over for patient, but also for interdisciplinary team to work together. As for the outcome, you can see that the big red line, which is all in behavior and technology, that is not that is directly aligned with um, a subject matter that is oriented in pilot testing, feasibility testing. So not a lot of RCT, not a lot of good trials, good as good methodologically strong trials. So most of this is in there. So it's acceptability, engagement, so function of the platform, and how it was serving them. After that, you have system level outcome, psychosocial outcome, and lastly, clinical outcome. So this was the least reported outcome, was any clinical outcome. So any improvement on health was not really the first thing that they thought about.
And this is because also there's a lot of confounding factors that clinical is less studied sometimes.
Tu veux-tu me donner un petit peu plus de contexte que je puisse travailler?
Ben,
Qu'est-ce que tu
j'ai
veux?
l'impression qu'il y a moins d'outcomes cliniques. Par exemple, pour le diabète, il y avait une revue, mais c'était un outcome, c'était par rapport au taux de glycémie. Mais pour le cancer du cerveau, ben, le cancer en général, c'est davantage relié aux symptômes. Mais il n'y a pas juste le portail, là, il y a beaucoup d'autres facteurs qui viennent en interrelation. Fait que c'est dur à étudier précisément. Puis à
Mhm.
isoler.
So I'm gonna try to do the best job I can translating what Stephen meant. Um, but the low prevalence of report is mostly oriented onto heterogeneity of the studies that were included. So clinical outcome were mostly oriented toward diabetes control or things like that. So diabetes as clinical for a certain type of clinical outcome for a certain type of disease, but it's not relevant for all type of disease. And because we were brought into a type of cancer, we didn't have a lot of clinical outcomes. Does that resume well? Yeah, it's good. Here you can see just a distribution of reporting. I think the subject matter of patient portal had kind of a popularity rise around the 2000, just before COVID-19. So you see the COVID-19 effect here with a slowdown on a shift of interest, and we were not really necessarily able to see impact long term out of the change of academic focus that is the 2021 to 2023. And we don't have the full 2024, so it's kind of you cannot assess 2024 as a full year for our databases. So you can see that with the shift, we kind of lost these interest in research, and our hope was that at least it would rise up again, and as a good way to do self-management and management of cancer. So it was a lot more relevant when we saw that as well. So for our principal finding, I've said the first, but one tidbit of context, they mostly use the EPIC function. I think it is implemented in some provincial Canadian provinces. We are doing it in Quebec right now. It's probably going to be the implementation that we go with, and in US it's quite prevalent as a system. That's why this is just a contextual effect. Only 4 studies were on symptom-related clinical outcome. I think we talked a little bit about that before. Some of the promising feature that was less prevalent but really interesting in terms of effect was education, symptom tracking, distress. which is a transversal symptom. So for somebody that is affected with cancer, distress is always there. So it was really encouraging for us to see it in some of the implementation, but it was not uh, it was not a general implementation. It was in our category of psychosocial outcomes. So it was quite minor as a representation. Um, all the remote consultation so the platform are not used for remote consultation, but also no implementation of patient-reported outcome in the platform as a data collection source. So you, there's not a lot of these functions implemented. Um, and a lot of things were hard to give any recommendation or structured conclusion around. All that is structured follow-up, education, active monitoring. It's only small sample size in a couple of contexts, so we were not able to really see overall trends about these functions. So we have seen that portal are really clearly improving engagement. So if you want to have a solution that can be implemented in EHR to provide better patient engagement, this was one really clear result. But all of that are all the other impacts, so all the other median or distal impact, because the engagement is a proximal one. So benefits on health outcomes or quality of life or distress or anxiety. It was not really well, it was not explored enough so that we could provide any conclusion on this. So we think that the way that research should go in that context is to have more outcomes, or to at least focus on different categories and try to have a full broad understanding of what happens when a patient is diagnosed with cancer and what that person could need as follow-up or evaluation, and also try to include the social determinants of health into account for research, but also clinical work, because we were not able to really do a good assessment of that except from age, which is quite intrinsically related to cancer as a diagnostic. So we have a question for discussion to try to lead you into the next phase of this talk. One of our conclusions that equity is not really implemented with the lack of really clear progress plus implementation. How do you think it could be integrated in the design and evaluation of these digital portals? And also, which functionalities do you think could provide the greatest value for clinical or research context in your view or in your understanding of what it looks like, or in the context of cancer, what patient could need or provider could need? So that's it for us. I don't know if Stephen, you want to add anything to this talk, but it's really okay if you don't have anything to add. I just
No,
want to be
this is
sure.
very good. Uh, Personally, I would like to have all these functionalities, but actually, I have no, I have no patient portal for me. I don't know if when I will have access to it. I don't have access, so I have to consult my care teams by phone, essentially, and in real meetings, but not in. I have not a portal, and I have to consult my personal emails to see what's going on with my appointments, for example. And I would like a portal to regroup all my my information in the same place. That could be very useful to me. But I hope that I will have that sometimes.
Thanks, Stephen. Do you want me to keep the question projected or I stop the screen sharing?
You can keep the discussion questions up, Maxime, and then if anyone has any questions, put in the chat, or if you want to address any of the questions on the board, feel free to unmute yourself um or write your responses in the chat. I'm gonna
Yeah.
stop the recording.